you may be already aware because you've already been here a couple of semesters, but there are things that I want to make sure you're aware of. As far as Canvas, any problems navigating that? Okay, so I'm glad you got that down. In the syllabus, you looked at how you get your grade in this course. You could jump up and down because how many papers are due in this class?
I didn't see any.
Well, you didn't see any.
Is there?
Well, I don't know. You tell me. You're supposed to read that, right? Is there? Any big papers?
I thought it was
Zero. You were right.
Okay.
Is there? I know. See,
I know.
that's what happens in clinical. It's like someone asks you a question and you assume you missed something or you did something wrong. Fake it till you make it. Okay? Just like, I didn't see any when I looked. And then you still could be wrong. We'll eventually take you to a place where you probably, I wouldn't say are wrong, but maybe don't know. Okay, so no papers. How about all those big presentations you have to do in here? Oh, isn't that nice? Because you're getting them everywhere else, right? Yeah, I know, you are. So no papers, no presentations. So how are you going to earn your grade in this class? 3 exams. Okay, the first one's worth how much? 25%. Okay. The second one? 25%. Okay, and then the last one? 40%. Whoa! Why do you think it's 40%? It's going to be from today till the day before you take that exam. Everything in the class. Do I have a final exam? No. And this is a semantic thing related to the university. You will not have an exam on finals week in this course. But your last comprehensive exam will be basically the last day of this class. Okay. They told me that I couldn't call it a final exam unless we had it on the final exam week. So when I say they, that would be administration, not necessarily our nursing or anesthesia one, but that is how the school does it. So I'm like, okay, that's fine. I can have one last exam that covers everything. And that way for your final exams, in your other courses, you can focus on those. And I'm not saying mine is not as important. It is to me, of course. But it kind of breaks it up for you. So you get that one done, knocked out of the way. Okay, this class, you'll know by your last class if you passed or failed. Boom. Isn't that nice? I don't think there's ever been, oh, don't be the first. I don't think there's ever been a student that has not passed this course. There have been a couple of folks that were close, that made it in the end. But I don't think anyone did not progress in the program because of this class. So that should, I hope, help you feel confident, but don't let it make you feel cocky. Because then we don't want you to be the first. So this class, 3 exams. Where's the information come from? And people don't like this, but it can come from anything that I give you as an assignment. Assignments would be all the reading, any of the lectures, any of the things we discuss in class, any of those little articles that you might see listed, like evidence-based practice readings or that kind of stuff that you see in the course. It could come from anywhere. I could ask you 2 or 3 questions on one of those articles, and you'd be like, that's kind of nitpicky. Okay, welcome to anesthesia school. I'm very empathetic, right? Okay. But you didn't, well, it doesn't matter if I emphasize it or not. Was it part of the reading? If it was, then you're responsible for it. Did I emphasize it? Maybe yes, maybe no. But you will see that this is a little different than like your undergraduate work. If you did like a RN, an associate's degree, RN, that's what I did. Very intense, but they gave you the stuff, you kind of memorized the stuff, you took the exam, and then you pretty much kind of done it, right? And when did you learn to become a nurse? When you started nursing, right? At least that was my experience. You probably started your first job going, I mean, you passed the NCLEX, right? You're a nurse, but you're like, I don't know too much about how all this works. But then you learn by either having a good mentor or scrambling on your own to figure it out. This is a little different because everything you learn in here really, you're going to need. And you're going to need to apply it to save people's lives or to not kill people. Because what we do is super, super serious. We make it look easy. Most of us make it look pretty easy. But you know, you're keeping that patient in a hemodynamic place that is viable with life. So they can go either edge. They can go too far up, too far down. You've got to keep them in that happy place. So let's say their blood pressure is super, super high. What are you going to do? You're going to bring it down. You're going to treat it to get it in a viable place. What if it's super, super low? You're going to bring it up. You've got the power to do that. you can save somebody's life that's circling the drain because of the procedure they're having by maintaining that hemodynamic status. Or if you didn't do anything about it, if the pressure is too high, what are they going to do? And whose fault is it? If their blood pressure is tanking and you decide not to treat it, whose fault is it? So it's a big responsibility. It's a huge responsibility. And people's lives are literally in your hands every time you do an anesthetic. So that's not to scare you, but the responsibility of it is huge. We make it look easy. People think it looks easy. Oh, they sit in a chair. Okay, the ABCs of anesthesia: airway, book, chair, or computer. Right? That's not what it's about. Airway, yes. Yeah, breathing, yeah. Circulation, yeah. You are maintaining the hemodynamics. People go, oh, it's just a colonoscopy. We're just going to give little boluses of propofol. People can die from that. If you're not doing, if you don't lift their airway, if you don't support their airway, they can die. If you don't recognize it, if their blood pressure tanks from the propofol you've given them, because everything down leads out, right? And you don't recognize it and you don't treat it, so it's your fault. What if you give the wrong drug? Could you kill someone? You know that from my senior nursing, right? When I was working, my first job was at Riverside Hospital. If you're familiar with that part of town, it's now a Publix. Different building, but I worked with someone in ICU that pushed potassium. It used to be in a similar container with either like normal saline flush or I forgot what, but it was in it looked identical. And she was a good nurse. She'd been an ICU nurse for a long time, and she just made an error, and it really could kill the patient. So in anesthesia, when that happened, it made me, I double and triple check stuff. Even still, it put the fear in me. In anesthesia, you could kill someone by not doing something you should do, or by doing something you shouldn't do. I don't want that to be me, and I don't want that to be you. So these checklists that we put in place, these routines that we put in place, the things that you're learning, you don't want to forget it. That's how important it is. The things and you're like, why do I need to learn this? Not like that. Not like that. You may not understand now why you need to learn it, but once you get in a clinical environment, you should be able to apply and understand why you need it. Really important what we do. In the syllabus, any questions about that? The main thing is in the syllabus, it goes through not only the NAP stuff, but also the School of Nursing policies. I'm expecting you as a grown-up and a doctoral student to read that. If you have questions, please email me. We'll discuss it if you need to meet in my office. I'm here all days on Fridays, and then I'm here one other day of the week, which may not be convenient for you. Right now, my schedule is set up, and I'm usually here on Mondays. But I'm always available by email, and then we can say, is it okay to call? You can text me. Is it okay to call now or whatever, and we can talk on the phone too. I'm accessible to you. It just may take me a second. But I'm expecting you to read the syllabus, and I'm holding you to it. Being prompt to class. Silencing your cell phone. I did mine, so if you haven't done that, make sure you do that. Now, if you're expecting an emergency phone call because your spouse is having a baby today, then let me know, and we will as a class, we'll agree to let that phone go off, okay? Right? And the other, on the negative end of that, the sad end of that, if you have a family member that is near passing, and you need to have that phone on because you're waiting for that phone call, just let me know. And the class, we will agree that that's okay, right? But barring things like that, if your phone goes off, we're going to embarrass you. And we're all going to like point to you and like go, ah, or whatever. We'll figure out a class thing to do, but something that will embarrass you and be like, oh man, I'm never doing that again. I'll leave my phone in my car. So attendance, being here, and I know you will be. You're adults, you're professionals, and you want to be here. But 10% of your grade comes from, so we already added 25, 25, and 40 for the test. That's 90%. 10% comes from class participation. Now, that's everything I want to put in there. Like impromptu quizzes that we have in class, attendance, punctuality, if we take a break, that you come back on time. And if you're going to be later, just let me know. We can work that out. As long as the class agrees that it's fair. I just want it to be fair for everybody. It's not fair for you to come in like 20 minutes late and everybody else is like here on time. Now, I know you can't predict a lot of things with travel and traffic in Jacksonville. That's why I always get classes early. So I live at the beach, I work at Riverside. It's a 35-minute drive if I get every light green going down Arlington Expressway over the Matthews Bridge to St. Vincent's. That's if everything goes well and there's no traffic. So I have to be there. Our first cases start at 6:30. We have 6:30 cases, 7:10 cases, and 7:30 cases that start. So I go early. Every day, I get there early. I probably get there 30 minutes before I get paid. And I've been doing this a long time. I still do. Now, a lot of people don't do that. But I have to allow for what if there is a traffic. Because if I don't show up to work, they cancel cases. And that means those 10 people that were going to get their surgery that day either can't or everything's delayed. Now, that doesn't make me a popular person with my anesthesia group, the surgeons. Patients probably won't know it was me, but I know. So I make sure I'm early, and that means on time. Also, I'm in the Army, so, you know, I won't have to explain this. Who else has service, fire service?
My husband.
Okay, well, hey, no, you do, because it's a family affair. If they're the service member, which would be me, and everybody in your world has been affected, right? So, yes, and thank you for your service, because you have to support that person that is in the military. I totally live that and get it. Sometimes it's frustrating. But for me, it's been good because in my 22 years in the service, they legalized same-sex marriage in 2015. And so my then partner and I got married on our 13th anniversary, which was cool. I wore my uniform. And then in 2015, when they changed the laws here in Florida that made it legal for us to be married, we changed our names. That's why it won't fit on any paper. Harmon O'Connor. It has a hyphen and an apostrophe. But I'm the Harmon part, she's the O'Connor part. And so the military, prior to that time, technically, I could have been kicked out with a dishonorable discharge. And regardless of what your thoughts are about that, I'm grateful that I've had the opportunity. And I understand what it means to serve. And I do think it's a family affair. And all the people that know you and love you, your family, his home, etc. So, thank you. And thank you, too. So you've got the syllabus down. Course outline. Sometimes that's flexible, because sometimes things go up in people's world that we have to make changes. This class is really, I'm the coordinator of the class, and I'm your facilitator. But we have a lot of guest lecturers that come in. We have people from the community that are CRNAs. Many of them have graduated from our program. They want to come and give back. So that's where Larry Ingvar, Cameron Cushenberry, Ms. Carroll does a case scenario thing with you at the end. Dr. McDonough likes to do a thing on ERAS. You guys know what ERAS is? Enhanced Recovery After Surgery. It's a whole new protocol of how to take care of people and help them recover faster. And from our perspective, it's really minimizing narcotics and increasing multimodal anesthesia. It also includes how much fluid should we give a person, so we do a lot of goal-directed therapy type things to give them the right amount of fluid that they need for what's going on. So we get a lot of guest speakers, and I think you'll enjoy them. And it's cool because then when you go to your clinical site, you'll probably have an opportunity to work with them clinically. Or at least you'll recognize us and know your face. So we have Diana Hathaway, who's at Halifax, one of your clinical sites, so she'll be here. Cameron has his own basic private practice. He was working in OB at St. Vincent's, and he may be still doing that, but he also has with some other CRNAs his own practice. So he goes to South Point Surgery Center. We just started that as a clinical site, so he does his own gig there. So I think you're going to enjoy the people that are here, but sometimes things come up in their world, and so what I have planned may change. The content will not, however. So the schedule is not set in stone. It is fluid, but that's our plan. Okay, that's our best laid plan for what we know. I like to use the expression, and you saw this probably in class, semper gumby, right? I was not a Marine, but I understand it. Always flexible, always fluid, always be willing to adjust and adapt. And it makes you frustrated because you want things to be, for lack of a better expression, black and white. Yes or no? You're welcome to the gray world. Yep. Even in your readings, you might have two different textbooks you're reading from, and one will say, here's the stuff, and the other will say, this is. So we'll try to come up, like with drugs and things like that, we might come up with a range that would include both. Because you go, but this book says this, and this says this. Yep, that's going to happen. It's going to happen. This will not be like I give you the information, you regurgitate it back, you've got to keep it with you. You've got to keep it with you in order to take care of those patients. And it will build over time. And if you're like me, I have to rememorize stuff. So if Dr. Shores or Dr. Self, Dr. Pavati, Dr. McDonough, they say, hey, Dana, we need you to do this lecture on blah, blah, whatever topic. And I'll go, first I'll go, oh, no. Then I'll go, okay, let me do the readings that you're doing. Let me look at their PowerPoints. Let me tweak it and make it usable. And okay, we'll do it. And you will be there too. You'll be able to be the experts in your area. You will definitely be airway experts, and even if you're not, people will expect you to be. And you will be IV experts, even if you're not, people will expect you to be. They're going to call anesthesia for all that. You're going to be the one that responds to codes in the hospital. So that ACLS stuff, I don't know how much you got to use it as an ICU nurse. It depends on where you worked, right? But if you haven't, that's you need that. When you take that class, or you don't roll your eyes and go, oh, not again. I'm taking this 20 times. Okay, take it like, I may need to use this tomorrow, and I'm going to have to be the leader of. I'm not just in the class, right? You're running the whole code because you may be the most experienced, most knowledgeable person. And even if you're not, we're going to think you are. So you better learn it thinking. You're the one that has to run it and know it and do it. I'm pretty good with the first 2 or 3 lines. Then after that, I'm like, anybody else here have any ideas?
H's and T's?
Yeah. That's exactly right. But if you can do the initial response and have a plan, go 1 or 2 depths in, then you'll be all right. But when you take the class, and you'll do this, you should do it at the end of the spring term, folks. Take it like it matters. Okay? Not just, I'm going to have it for my job. Yeah, you do. But you have to have it because your job is all-encompassing now, taking care of those folks. Okay, no questions on the syllabus, or no more questions, I hope.
I have a question, though.
Yeah.
For the Basics of Anesthesia textbook, the 6th edition, that's also one of the textbooks that we need to purchase.
If you don't have it, it's okay, and you can use an older version, it's all right. The stuff, for the most part, doesn't change enough. There might be, sometimes they add chapters or change chapters. They'll delete something or add something, but if they do, you can always borrow friends and just look at the part you're missing. You don't have to use that book, but I recommend it because it puts it in a place where you are now. You can read it and understand it. Where Miller, God love him, so that's what I'm going to say. We used to use Nurse Anesthesia, which was a book written by a nurse anesthetist, which we no longer use, which I liked as well because it was kind of a blend between what I call Baby Miller and then Big Miller. And so I liked that one because it was a nice bridge, and also because it was written by Serenade, but we're no longer using that one. So, but the edition isn't quite as important, so you could buy a used one or an old one or whatever. And if there's issues, then I just don't think I haven't seen it be an issue for students because sometimes they'll have the older one because they can get it like for $20 instead of 150 or something. So you should be okay if it's a different edition. Yeah.
Is that Naval Health that you're referring to?
Yes, Naval Health.
Why aren't you using it?
That would be a question that we would talk to our program director about.
So don't
So
focus on it.
yeah, well, so I think it's a great book, but it's more of a political decision by Dr. McDonough not to use it.
I'm going to answer that. Whenever we were in Washington and he was talking to the legislators that we were discussing with, one of his points was that we use the same anesthesia textbooks as anesthesiologists.
Oh.
So if we used one that was by CRNA, that would not be true, I would imagine.
But we have all the legal health texts on SharePoint, and they do make sense. So if like you're not getting a concept, and then his lectures are available free online, and that information is also on SharePoint, and he makes sense. Like if you're not getting it from Miller or from Stolting, like he makes more sense.
I can neither confirm nor deny that that's my preferential textbook. But you'll find, like, if you look at the references and how the books are written, the references are really the same. But I understand, I think of it from a CRNA perspective, and so, but it's more of a political thing. And I like your explanation, because that's not the one that I was thinking, so that, and you're the one that said it, so.
Yeah, they said that at CRNA day as
Yeah,
well. I think if
But
anybody
we
was there.
that's
Oh,
repeated
God.
it, that we use the same textbooks, we are subject to the same standard.
Yes, perfect, yes.
For the MH lecture.
Yep.
It says scrubs, lab tech, certificate.
Yep.
We'll be here in our own scrubs.
Yeah.
Like, we won't be in a hospital, like.
No, you'll be here. On that day, unless, now that's subject to change, but I would like to, because I like to do a little, airway exam. You had 2 airway lectures before that. You just had the exam on that, so you had a basic airway and advanced airway. And there may be another time or two that we'll have you in scrubs too, but I have to check with the other faculty so that they know. Otherwise, they're going to be just professional. That doesn't look professional. If you do wear your scrubs, you wear your scrubs, your UNF ID, and a white lab coat. And don't look like, just rolled out of bed kind of thing. I don't press mine, and when I get mine out of my we have a scrub machine at work, and it does look like I just rolled out of bed. But, just make sure they're clean and nice. I don't care if they're pressed in starch, but, they should look nice. And then I would bring a stethoscope to you that day. I don't know if I put that on there. But, so that could change. We may have it earlier, before, or after, but I'll let you know. And then there might be times in class that you'll be dressed how you are, and I'll say, okay, pants off, no. Not really. But we may have you do some things, like do an airway exam. You can do that dressed professionally. Heart and lung sounds you could probably do pretty well without being in scrubs. But it also gets you in practice for the proper protocol for coming to the campus in scrubs, which would be clean scrubs, your UNF student ID, and a white lab coat. That's an agreement for me. Contacts. This is my contact information. Man, my picture is supposed to be this big, but it didn't work out. We are now, our offices are in building 4, and we're up on the 2nd floor. So we're not in the immediate nursing area of 39A, which we've been the whole time I've been around here, so it's a new change for us. And we do have labs right outside our offices, which are cool. We have like 3 or 4 really nice rooms. We've ordered some things for it. Right now we still have old stuff. So if the new stuff comes in before we get to certain areas, we will get to use the new stuff. If we have to use the old stuff, we'll just have to be patient and kind of get it from a more extra simulated activity. For example, some of the older mannequin hands we have, you could try to intubate them all day, and it's just almost impossible, okay? But you could still learn the techniques, and we would still go through the motions of trying and practicing. They've just been used, 10 years. So we do have new stuff ordered. I'm just not sure it'll be here in time for, it will be here eventually for you guys, but it just may not be here in time when I have plans to do some of that stuff. So be patient with that. It'll eventually get better. I just want to make sure you know I'm over in building 4, room 2402. That is my cell phone number. I don't have an office phone. Years ago, Dr. Loretta said, we're spending too much for office phones. Who's willing to get rid of it and use your cell phone? And I'm like, I will. I put that on my taxes too. I'm using my cell phone for work, right? Right on. I still have to pay for it, but still it helps. Every little bit helps. I just want to make sure you knew how to get in touch with me. Again, I'm here on Fridays for sure. And then one other day a week. Course outline, let's just take a peek at that real quick. When it tells you faculty, that's usually the person that will be teaching that class again. Sometimes that's subject to change, but those are the commitments that people have made, if it's not me, that will be here. Most of the time I'm here when we have guests. But there is a time when I won't be here. I will be at ANA in Seattle this year. I'm not presenting a poster, I'm not doing a lecture, I'm just going. So I will actually miss 2 of your classes. I have Diana Hathaway doing a lecture for us, and she's done this several times before. So she's one of our former students. She's the clinical coordinator at Halifax. So she's real familiar with things, and she'll do you right. The only bummer is for me that I won't get to see her and take her. I usually take her out to lunch or something like that after. So I'll miss that. And then also Cameron Cushenberry, who does your basic airway lecture. He again is one of our former students, and he's done this lecture several times for us. But I won't be there because I'll still be at ANA. Yeah, it's extended. Yeah, it's awesome. But I will miss hanging out with you guys. But if you have any questions about the lecture, people say, well, I've heard students say, well, we have so many guest lectures, we don't know what to emphasize. I already told you what to emphasize. everything you read, every PowerPoint, every little article that I have in there, and who presents the content, though you may enjoy it some more than from some people than others, that part doesn't matter, okay? Wouldn't matter if Dr. McDonough taught this course or Miss Carol, soon to be, not too much longer, Dr. Carol. She's been working on EDD, and she's what they call an EDDC candidate, so she's well along the way of getting her doctorate degree. But whoever taught this course for us in this program, it would be pretty much the same as far as content. So don't worry about that. What do you have to study? Everything. And you'll go, I don't remember reading that. Okay. I'll find the page and chapter and we'll talk about that. Oh, but I didn't emphasize it. Okay, I agree with that. Okay. But again, I'm totally fair, I think. And of course I do. I try to be fair, and sometimes in the past, it hasn't happened much in the last couple of years, but prior to that, when I was developing the test and all that kind of stuff, there were mistakes on the exam. If you ever find a mistake, I'm giving you the credit. So you don't have to argue and all that kind of, just show me. And if you found where the correct stuff is, I'll go, yep, that's a mistake, and I'll just fix it. So any of that kind of stuff that happens, you definitely, it's your benefit, your gain, my loss, and then I fix it so it won't happen again. Okay, so after the first lecture, then I plan to do an NH lecture. How many of you really know about NH? Yep. So we can have you do the lecture instead?
No, ma'am.
Oh, okay. The answer is always, yes, ma'am, whatever you say.
Oh, yes, ma'am.
Whatever you say.
As you wish.
Yeah, thank you. I'm just kidding on that. But every place you go to will have in the OR environment will have an MH cart where they have, what's the antidote? Thank you, I'm glad you knew that. So when you go to, even when you start doing your observations this semester, you know, people would expect you to know some basics. So that's why I go over it this semester again. You probably learned about it as an ICU nurse, but how much did you really have to deal with it? Not much. And even in anesthesia, thank goodness. Rarely do we have to do much with it. But that's why I review it. I take the time to do that. So that before you start going in the clinical setting as an anesthesia person, you'll at least have it in your mind, okay? I don't want you to go in blindsided and someone take you out. But then also that content would be potentially on your exam.
Have you heard about the new antidote? I don't remember the name of it. Samsey was just coming out with it as I left.
The only thing
It's expensive.
the only thing I know is there are two types of dantrolene. One is the reconstituted, it's dry, and you gotta mix it up in 60 cc syringes, you know, and you need 3 or 4 people to do that in order to be able to treat someone that's having an MH crisis. And there's the new one that is already reconstituted, it's more concentrated, so it's much easier to get into the patient fast. But it is,
So it's still dantrolene.
I think, now, yeah,
What is it?
Renovo or something like
Yes,
that.
yes.
So it's still dantrolene, but it's in a different form. It doesn't have to be reconstituted. Unless there is something new, and there could be something new that I haven't heard about yet. It's possible. But I'll review for that lecture
No,
before we have it again. So maybe
I think it starts.
it's a
with
Renovo,
R.
I think.
Ryanodine.
There you go. But that's just, it's a liquid form of it. It's more concentrated too. So most places that I have practiced at don't have that because it is so expensive.
They can't be exposed to light. It's like the amiodarone and premix that some places we put in their crash cards and other places won't.
So in the military, I get to use all that stuff. And then in my private practice, but what's cool is when the stuff expires, then we can do little, at work, I do like little MH crisis events or whatever. And so now they have it as part of the new employee orientation, so I'm on this little video. I wish I wasn't, but it is kind of cool. So we do this little MH event kind of thing in the OR and get to use it all. So people are over there just slaving away, reconstituting this stuff. So you get to practice it. Yeah. So we'll talk about MH, and that's the reason. I just want to make sure you've had it. We may talk about it again. Dr. McCarthy, who you know, she is an MH expert as far as nationally, and she sits on several boards or committees related to MH. So she's been around it a really long time. She's kind of like our faculty expert. Sometimes she requests to do a lecture when she's here on MH. So if she does, we will accommodate that for her. It could be this semester, it could be next semester. But whenever she tends to ask that, and when she does, we make space for her. And she's the expert. Okay, on 10/27, yes, we have your second exam, and Megan will probably be proctoring that for you because I will be at FANA. That's down in Tampa this year. Just sounds like I live a great life. I've gone to Seattle and going to Tampa. It's pretty cool. I used to go to FANA all the time because I could do it in lieu of my Army weekend. I'm like, let's see, Army weekend or FANA. I think I'll go to FANA. The Army stopped paying for me to go, so then I really haven't been in a long time. Plus, I only have so much time. But this is the first one I've been to now in a couple of years, so looking forward to going. So Megan will proctor that exam for you. This, yeah.
Dr. McDonough kind of said that we were encouraged to go. So should we not go? We can leave that. We can leave
Yes,
that.
you could go, first of all, the exam will be early, so you can still go, it still goes Saturday and Sunday. It's like, I think it's sort of, I don't remember if it starts early in the morning Friday, but
It's in the afternoon.
So it's, I think it's like Friday half a day, all day Saturday, and half a day Sunday. It's usually how they set them up. So you can still go.
And just miss Friday.
Yes.
Is Friday is bad or something? No, it's Saturday. Is that Saturday?
You want to miss that? Okay. In this term, we're missing more classes than any time before since I've taught this class. We got Veterans Day, Thanksgiving we always miss. But the last class on the 13th, when you meet together, Miss Carroll usually does she looks at different case scenarios and she discusses those with you. Because one of the things that you'll be responsible for in your practicum course will be having 3 care plans. A general anesthesia care plan, a regional anesthesia care plan, and a MAC anesthesia care plan. So she will talk a little bit about that. And once you get into your observation days, we'll start talking more about that and those requirements. But what does MAC stand for? Monitor anesthesia care. It can also mean something else.
Minimum alveolar concentration.
What's that?
It's the amount that 50% of the people will be anesthetized.
Something. It's ballpark, it's close. So, how do we measure? We have these anesthesia gases, right? What's one example of a gas? You got SIBO, what's another one? Isoflurane, what's another one? That's right. Okay, so those are the 3 you mostly see. The old days we had halothane. We had lots of other things, but Dr. McDonough, when he started, was pretty ether, I think. I think he really literally did. Amazing. So those gases, how do we know how to dose it? Well, MAC value is how we do it. And you may, when you're reading a question on an exam, for example, you're reading in a textbook about MAC, and you know which MAC we're talking about. Are we talking about monitored anesthesia care, which is sort of like moderate sedation with probably a little propofol thrown in. So when we talk about moderate sedation, a little Versed, a little fentanyl. If we add propofol to it, then it probably becomes an anesthesia, MAC, monitored anesthesia care. But no, just make sure you know the difference. Sometimes we use those terms, we say MAC, and you have to take it in context. Which one are we talking about? But that's how we determine basically the dose. It's the MAC value when we talk about gases. So this is the basic plan for the class. Sometimes things change. We try not to. When Dr. Self is planning to do the positioning lecture, he said there were some CRNAs at Halifax who were interested maybe in doing some lecturing for us, so he may arrange to have one of his peers, come and do that lecture instead. So that's the only one right now I'm not too sure about. But he usually does it for us, but he said there were some folks who are kind of bugging him and wanted to do some lectures, so that may or may not happen. We'll see how that goes. You can see that the course is organized by weeks. And it gives you the basics that you need in order to do a good job with that. Sometimes I update these. Usually if I make an update, that will be, usually you get an announcement, I think, in Canvas that I did something and changed something, so you should know. Let's see if I can see anything else in here that jumps out at me that I wanted to mention. Sorry if you're watching at the board, you're dizzy. All right, I wanted to mention too, a little bit about student wellness. And as we do that, I want to talk about, we mentioned active shooter earlier. Like I was saying, I had to go under the desk when I was a kid. Now we have the active shooter thing. I don't expect that to happen while we're here. We can't hide in this room because we've got this glass thing, so we can all, like, there'd be somebody screaming in the corner, we're like, you know, but we don't have a way to lock this from the inside. So this is really not a safe room. So, and if you're in here, there's motion things going on too. So you know somebody's in here with the lights going on. So if we were to have a active shooter situation, let's say we heard something like at that end of the campus, then we would want to try to get out of here. And well, yes, I will be the last out, okay? But I'll guide you. What we would do if we had to leave this room for whatever reason, let's say, I don't know, whatever, some kind of disaster, not only active shooter, but we would meet, you know where the Gandhi statue is? It's, if you go out these doors, there's like the bamboo garden, and then you keep going just a little further, there's the Gandhi. That would be our rally point, okay? That way I can see who's here and who isn't, like who we're missing. Because it's my responsibility too, God forbid, if something like that to happen, I have to be able to give them names and who's here and who isn't. So that will be our rally point. So that'd be a good quiz question, right? Next week, like where, you know, if there's a disaster, where's our rally point? Just say Gandhi. I figure if we're there, there's two things. One, we'll probably be safe and protected. And two, if we go, if that's where our last moments are, then we're close to God, right? So I figure we got it both ways. But that would be our rally point if we had to leave this room. But for active shooter, what's our first thing you want to try to do? You want to try to run. You want to try to get out of that environment. If you can't do that, the second thing you want to do is hide. You want to hide. So that's why I was saying if we can make the room dark and we can hide in one corner where they couldn't see. We would also, if we had a lock on this side, we could lock the door. That would be very helpful. So if you can't run away from it, you want to hide. If you can't hide, you got to be ready to stand up and fight. Now, I don't want to do that. You don't want to do that, really. But I would do that. I would do my best to defend you guys if I had to. And yeah, I have been trained in military combat. I can shoot a 9mm as bad as anybody else that's been in the Army 22 years, or you know, M16 rifle. I don't carry those with me. With probably a good thing, because really I'm not that good of a shot. But I would do what I could to save you guys, as I would with it for any human being. I would try, and I just hope that never happens to us while we're here. That's all. Also, just be aware in your normal environments as you're going to and from places when you're shopping. Just always have an awareness, I mean, I would say be paranoid. I'm just saying be aware of your surroundings. And a lot of that you can help prevent stuff. Like if I'm doing something and I see there's a confrontation over here, like in the grocery store or something, like I don't go check out and see what's happening. I go the other way. I go to the beer aisle. Oh, that just came out. I didn't mean that. But I avoid the situation. I'm not like going to go into the situation. If I'm in a situation and I have to help someone or respond, then I'm going to act. But otherwise, I'm going to be the first to run. In this situation, since I'm the responsible grown-up here, 14-year-old boy comes to my mind, my spouse says, but I will make sure that I'll do my best to keep you guys safe, and we know our rally points, so that's important. Okay. Student wellness, there's tons and tons and tons of things you're paying for in your tuition. You know that long list of itemized things you're paying for tuition? You're like, what is that and where is that? Oh, a fitness center? I wish I had time, right? We have a state-of-the-art fitness center. It's awesome. So if you can find a way to make time and carve out time, it's there. We have counseling services. Then there's some articles here from AANA, the student portion, that give you some ideas. This is the one I really like. 6 steps or 6 tips for completing your SRNA program. Today's probably a good day to discuss that. I'm optimistic that you will. Why will you complete this program? Yeah, you each probably have your own reasons. Some of them may be, 1 or 2 or 3 or 4 or 5 years old. A lot of you be for your own self, for your family. But no matter what happens or how hard it is, how stressful it is, you need to find somebody you can talk to. Maybe another peer in class, it could be your significant other. But if what you're doing isn't working, then you need to get some help. By help, I'm not saying, we're gonna sign you up and lock you up in a place. Though, I have thought that could be beneficial a couple times, but if you need help, please ask for it. I had a friend in anesthesia school that just was like, I don't know how to cope, I'm getting all this pressure from my life. Like, I can't, the honey-do list has to be thrown away for a few years. Like, barring changing a light bulb or something that takes you 2 seconds, you will not be the partner that you've been. You will not be the spouse you've been, because you're barely going to keep your head above water to maintain, to be able to stay in this program. And until you're really living it, your family doesn't really get it. If you need help, don't be afraid to ask for it. So here's a guy that prior service, kind of a tough guy. I'm a man. I'm in control. I can do it all. And he realized that the things that normally work for him, the coping mechanisms that we all have our own little ways of dealing with things. He realized it wasn't working for him. So he went to the counseling. He went to the counselor. I didn't even mention it. That I said, hey, you need to go talk to someone. Because I may have been one of those people in his little group of friends. But he went to talk to someone, and it really helped him. Just to have somebody impartial he could talk to, and it really helped him get through the issues. He was able to then find a plan to be able to communicate with his wife and spend time when he could. He made a date night every week. Okay, I'm not available XYZ, but like, for example, for you guys, Friday night's a good night. You've worked hard during the week, you've been studying and preparing. Most of the time, things aren't going to happen Saturday. Sometimes you have to do some things on Saturday, but Friday night's a good date night. I have 2 hours every Friday. It's just us, okay? It could be your family, watching movies. I don't know, whatever it is for you guys, but I started that in anesthesia school, and I'm still doing it. So tonight, date night, it's good. You need to make that time. And if, as far as extended family for holidays, you may miss a lot of holidays with them. Or you may be able to do it on the week before or the week after for one day. You're willing to take up like 4 hours of one day, but make it and let them know. Let them connect with them so that they know that there's a time that you can do something. Because they're not going to understand. And your job, you just want to survive this. You want to pass. And they're not going to get it because they're used to you being your normal person and your normal competent job and having a normal regular paycheck and all those things. They're like, you're going to school. What a cush thing. And they may, you've talked about it's going to be hard, it's going to be tough. But really, when you're living it, it becomes very hard. So seek help, please, if you need it. The university has it. And then you're like, now I have to make an appointment. How am I going to do that? If you need to take time out of this course because you're concerned, all you have to do is tell me. You don't have to tell me what it is. You just say, I have a counseling appointment here on campus. Fine. I won't take any points away from your attendance grade. You're more important, okay? And your peers can help cover for you and help you catch up. But I just wanted you to be aware of things that we have available. And I thought this article was good because it gives you some tips about how to maintain and survive. Have at least one mini hobby, and you're thinking, are you kidding me? How can I'm going to start knitting and crocheting, right? I don't know, whatever it is. You know what it is. For me, it's bodyboarding, or get my little bodyboard out, my little fins on, and like out in the water. It's always overhead when you're prone. Just for the record, those of you that surf get that. So whatever it is you like to do, doesn't matter, unless it's excessive drinking, and I don't recommend that because it's hard then to maintain your study habits and get up the next morning and go to clinical and all this kind of stuff. It's not good. The month in review is good with your family. Make sure you get enough rest. I know, that's hard. Eat the best you can. If you have 2 choices, try to choose the better one. Try to eat healthy. But don't stress over it. If it's another stressor, forget it. Go to McDonald's, go through the drive-thru, do whatever. But try to have conscious eating. You need rest. When I was in school, I probably had most nights, for those 3 years, probably, I don't know, most nights probably 4 or 5 hours of sleep. And then sometimes I would have like a full 8, which ended up being 10. And I don't know if you can ever catch up from your sleep, but make sure you rest. If you pray or meditate, make sure you don't forget the spiritual part of you. Because that's gonna be what's gonna help guide you through this whole thing and make it. You know, don't neglect that part of you. And it might only be, maybe you used to pray, like, you know, some people have habits where they get up and go, oh, 20 or 30 minutes every morning or whatever. You might have 3 or 4 or 5. Okay, take 3 or 4 or 5. Just don't neglect any aspect of your life. You're gonna have, it will all be neglected. But make sure you take care of the whole of you, okay? So you can use this guide to look through, and I thought I had some really good, helpful hints to help you through this journey. And the reason I'm having this conversation now, because the anesthesia portion, boom, it's like hitting a brick wall. And this is the first week, so I'm not trying to be gloomy. But myself as a student and my previous students, I've seen this happen, regardless of male, female, regardless of ethnicity, regardless of life situation. I see the changes that take place in your survival. So the coping mechanisms you have, try those first and see if they work. Make sure that you choose the healthy ones. And if they don't, please just get help. We can get you help. If you are a person that has a personality related towards addiction, you will have the opportunities for diversion and use in this program. As a matter of fact, it's one of the biggest problems anesthesia providers have. You may have known some peers in your ICU days as a nurse that was, you know, got caught or found in the bathroom dead, or those things happen in anesthesia too. And we have more autonomy, therefore we have greater access. So if you are one of those people, and of course, if you have that mind, you're thinking you can outsmart everybody and it's all going to be okay and I'm in control. It won't ever happen. If you have a friend in class that you think has that issue, confront them, and by that I mean don't duke them out, but discuss it with them, ask how you can help, and then get them help. Go with them, drop them off counseling, get them help. Because when someone in our profession ends up using and becoming addicted or diverting, it really doesn't end up very well. There's only a few things that can happen, really. The person dies from overdose, the person is in jail, or they're a forever recovering person. And if it means you can't be a CRNA and you're alive, there are other options to choose from in life if you could still live a happy, successful, and healthy life. So please, if you have problems or see a peer with problems, make sure you help them get help. And I'm not talking coming to me in my office, though you can. I don't have a lounge chair with like a chaser. You can like tell me your problems and stuff. And I charge like $250 an hour. So that's not a bad idea. But make sure you get help for those people. Okay, it could be you. And of course, you're not going to, I'm in control, it won't happen to me, it's all good. I know, it's gloomy, isn't it? But because it is a risk, and we're at high risk in this profession, I felt the need to mention it. All right. Wellness, look at these resources, and if you need them, please use them. All right, let's talk about our little bitty. Does anyone need a restroom break? Okay, 5 minutes. Thank you. Expect to remake any of the exams you missed, which would be essay. Ooh, I wouldn't want to do the last one that way. I wouldn't want to do any of them that way, but so then usually multiple choice would be the bulk of the exam. I may have some fill in the blank, may have some matching. There may be short answer, some diagrams. Maybe you have to know what they are, what they mean. But that's basically. And usually they're anywhere from 50 to 90 questions. It's easy to do it within one class period. Usually people finish pretty quickly, and so we still have time. That's why I can do the English lecture. Now, if you have one person in class that takes like 5 hours, too long, I will stop you at 2, okay? So you have 8 class period, but everybody, the rest of us want to continue on because you don't want to get behind. But I will give you a time limit for each exam specifically. I'll let you know that day. But mostly, if you're going to just, in one word, multiple choice, 2 words, multiple choice mostly. Okay? So this particular introduction, these slides, Dr. McDonough did the first set, and I decided just to keep them because it's nostalgic for me. when I took over the course. Just a little bit about, does this work? I don't know. So, my credentials, CRNA, Certified Registered Nurse Anesthetist, Doctor of Nursing Practice, Yahoo, Master of Arts in Teaching, Master of Science in Health, and I think that covers those. Oh, I have an MSN too, but because I have a DNP, I didn't put it on there. So the MSN was in nursing anesthesia. Advanced Registered Nurse Practitioner, in some states it's what? Advanced Practice Registered Nurse, maybe, APRN. I can't even say it because we don't do that for you yet. But that really is the best way to do it. I think we'll eventually get there. The objectives of today, we'll talk a little bit about anesthesia practice. Wow, this is why we're here, right? This is the absolute coolest profession. And you probably interviewed a bunch of CRNAs before you got in to go, is this what I want to do? Or you just look at the paycheck and go, this is what I want to do. Let me tell you this, the paycheck is not worth what you're going to have to do the next 3 years. Not worth it if that's your motive. If it's just the money, find another way to make good money, okay? Because honestly, it won't be worth it. But the money is a really nice benefit for having a job that you love, that gives you a good lifestyle, that lets you take care of patients one at a time. Oh yeah, new concept. One at a time you're taking care of. Now you're watching every breath and every heartbeat for that one patient. And you're making life and death decisions with that one patient, but you only have to think about one. You don't have to worry about your 1 or 2 in ICU that are somewhere else. And rarely do you have to do a bed bath. Not to say that's not important, because it is. Because if you don't do that kind of stuff, what happens? Bed sores, right? And then you'll be seeing them in the OR because they'll be getting your INDs on your stable area and all that kind of stuff. They're really fun cases with them too, by the way. Just as fun as the bed baths. So you want to prevent them if you can. We'll also talk about the different kinds of scopes of practice, what some of the standards are, and your role as an SRNA, Student Nurse Anesthetist. Now let me say this. You have some credentials now. Registered nurse, you say after your name, or you might have CCRN because that's an exam you took that made you, I don't know if it's called certification or I think it's a registration, but so your CCRN, your an RN, but an SRNA is not a true, real legal title or role. I mean, it's a role that you have, but it's not a certified anything. So if you turn in work for your papers and that kind of stuff, some professors don't care, but SRNA would not be a true title. Like you can't use that in the world. It's not a credentialed kind of a thing. But it tells us who you are now today. So when you do your work with your evidence-based practice class, and you do your DNP project paper and those kinds of things, you will put like RN, CCRN, or some of those kinds of credentials, but you wouldn't really put SRNA. Now that's how we refer to you, because in the clinical setting, you're not an MDA, you're not a CRNA, but you are an SRNA, which really refers to your role. You're a student. Registered nurse. Oh, it's so awesome. You really are. You're an SRNA. But it's, again, not a credential title. All right. Oh, Dr. McDonough, love him. He loves history. And he really likes medical kinds of history and nurse anesthesia history. And he said, well, let's start at the beginning. Where does the word anesthesia come from? Well, it comes from this Greek guy, this Corides. And, he's saying, we have this mandrake plant that we make wine out of, and it induces this sleep in people. Okay, so we're going to call this sleep or lack of sensation. We're going to call it anesthesia. And then, a few years later, we got 49, that's when he lived, 1846, a few years later, Dr. Holmes comes along and says, hey, what is this stuff? We will call this stuff anesthesia. And if as an adjective, if we give it to someone or do it, it's going to be called an anesthetic. So that's where the terms really came from. People have done all kinds of things to get good sleep throughout the ages, as long as there have been people. They have done all kinds of things to reduce pain once they get injured or harmed, to help reduce that. Or they have their own ways of trying to fix things. And thank goodness we have modern technology, because things are so much better now than they used to be. But we want to eliminate pain. We can't. I don't think it's possible as long as we're in these bodies. We are materialistic, humanistic beings. and pain is part of it. But a lot of it is here. And we are going to be giving people drugs to interfere with here to help with the actual physiological process of pain. When people are under anesthesia and the surgeon makes their incision, if they're not properly anesthetized, what are you going to see on the monitor? Heart rate's going to go up. What else is going to go up? Well, if they were breathing spontaneously, that's going to go up too. Aha. So people are going to have that response if they're not what we call deep enough, right? We'll learn more about that as we go on. Oh, and there he is. This Cordes, and that's the goddess of discovery. He's got the little, that's the mandrake plant, I guess part of mandrake is that. And then I'm not sure. I don't know. This is nostalgic for Dr. McDonough because he was in school in Boston, and this is the place he used to go study. So he likes to have this because I guess he remembers when he was a young lad. And you've probably seen the lecture where he shows you when he's like 2 years old or 3 years old, he's got the bow tie, because this was not a new phenomenon type thing. We all know because it's the same thing every time. So he is very predictable in that way. So when you know him, what you see is what you get. I have not seen this change in the 12, 13 years since I've been in his presence off and on. What you see is what you get. And you will learn some of these things over time that if you know it about him, you know it's true. So, and this is not the way I would word this question. Doesn't it sound like Dr. McDonough? Of what does it consist? Anesthesia. Anesthesia care. Of what does it consist? Okay, that's the how do you say it? Socrates. Yeah, well, yeah, that. Or it could be a Jeopardy question. It could be a Jeopardy answer, right? Of what does anesthesia care consist? Okay. Rendering patients insensible to pain, managing their condition, that would be their hemodynamic status, right? When they're having surgery or a procedure done. Can you imagine, yeah, I'm sure you can, from a nursing perspective, someone needing to have, let's say they may have some colon polyps. And we've got to go figure out if, we can fix those polyps without anesthesia. Imagine caring for the patient that was getting that procedure done without anesthesia. You'd have to have arm, feet straps, and body straps to hold the person from, probably, or sideways, right? So you'd have to have that person strapped down, and it would be just as traumatic for you to see it, to see that form of torture, as it would be for you to experience it. Well, I'd rather not experience it. I'd rather see it, but I'd still be traumatized. Post-traumatic stress, right? Anesthesia is such a great thing. You can alleviate people's pain and discomfort when they have these procedures and surgery done. That's what we do. But during that, it's not as easy as it sounds, because you've got to keep their heart rate, their blood pressure, and all those things they're breathing, or you're controlling their breathing. You've got to keep all that stuff within normal limits. Keep it viable for life. That's your challenge. So what involves you in your practice as an SRNA, as you're learning? You're going to have to do a pre-op evaluation. And based on that, you come up with a plan. Then you're going to implement that plan. You're going to give your anesthesia. And that doesn't stop there, because then you're going to transfer your patient, drop that patient off to an IC nurse, or PECU nurse, usually PECU nurse. And then once you've done that, you're still not done, because you've written post-op orders for that patient. And if it's someone that's in hospital, then you're going to probably be doing post-op rounds the next day, or even that evening before you leave. Not only that, but you will be called upon to do ACLS, resuscitation code blues. You'll be responding to those. You'll be placing central lines, art lines, but mostly you're going to be having to do the PIV, so they're going to call you in the middle of the night. Can you get a look? And they have their, 2 o'clock antibiotic is due. They didn't have a good IV. I'm sure 2 o'clock is not when that started. If you came on shift at 7, for example, it's one of the first things you do as a nurse, you assess your patients, but don't you flush the IVs and see what's working and whatnot? I'm just saying. And then they call you at 2 in the morning. You're like, I just got to bed. I've just been laying down I was just asleep 20 minutes because I've been up all night doing stat C-sections or whatever, multiple traumas in the or whatever. You're like, but you will be called upon to do that. And you'll take your little ultrasound machine, because by then, anything that was viable, they've wrecked it, it's gone. And then you're the expert. But imagine you're the expert in the worst case scenario. Because they already mucked up every good one that could have been there. See, that's a good word, right? That's good. Another time you'll get called on these code situations, you'll go down to the ER. And if you happen to be at a training facility with residents, those ER residents, let me do it. Let me intubate them. I'm the doctor. By the time you get down there, when they call you, you will have the worst set of circumstances to get an intubation. You've already had 3 or 4 people try, so there's tons of secretions, there's probably blood in there. And even if it was a great airway that anybody could get with almost their eyes closed, you can't really do it with your eyes closed. But by that time, there's swelling, there's secretion, there's who knows. And you've got the worst situation you've got to respond to. And again, these are always in the middle of the night. Doing central lines, IVs, intubating people. It's already after a bunch of people have already tried. And then you're the expert. Yes, I'm the expert. You have made it impossible for me to do what I need to do for you right now. All right. Where do we practice? Oh, yeah, hospitals, and most of your rotations will be at hospitals. We also do anesthesia at ambulatory care centers. We also do them in private offices. We can work, in the state of Florida, we can work under a physician, but we can still bill our services privately. So we can still have our own anesthesia nursing center. We can have that business, but we still have to work under a physician. So I could go to a dentist office and be the anesthesia provider there. I could go to the podiatry office and work with them, but I have to be under a, medical direction or medical, that's not the right word, but a physician in the state of Florida. And I can still make the money. Speaking of money, when we, like in my practice, we have one physician who's supervising 4 of us. If they were to do that case their own, they would get 100% reimbursement. If they supervise us, they get 50%. So they get 50% for them, they get 50% for us. Times 4, right? So they get 200%. So we're a pretty good deal for these guys. But we're not seeing that in our pockets so much. They take good enough care of us that we feel like it's worth it. But that's because we were ICU nurses, right? And we're making whatever we're making an hour. What's a typical hourly rate for an ICU nurse now? 30? Man. 25? 23. I was going to say somewhere between, and that's awesome. I'm going to go there. Well, not more, I don't think. Compare that to what CRNA, let's just say for hourly, even though a lot of people are salaried. I would say, I don't know, 65 to 75, probably an hour. But along with that comes all that responsibility too. So these are the places we can practice, and there are probably other places. Dr. Self is working on a ketamine clinic. He and some physician he works with are going to start. They want to start a ketamine clinic down in the Daytona area. So hang the shingle, provide the service, and take care of folks. And in forward areas, I have never served in combat, but I know what forward areas mean. CRNAs have been doing anesthesia since the Civil War, but if you look at how things look historically of anesthesia, it's really very physician heavy as far as, here's the history of anesthesia, and you will see in your textbooks that this is so anesthesiologists will be able to take better care of the patient. Whenever you see that, I always put in my head anesthesia provider. And I'm not saying we are better or worse, because they have medical training, we have nursing training. They go to medical school, we go to nursing school. So I think we are collaborative and we all work together for the same goal, which is taking care of our patients. The anesthesia portion of your care is not really any different than what an AA does, or an MDA does, or what we do. We learn all the skills, we do all the stuff, but our foundation is different. So a physician, it's their 4-year degree, you got your 4-year degree. Yours was in pre-med, yours was in nursing. Then you get most people, not you guys, you're going right from BSN, but then a lot of people will get there, like for me, I had my MSN in nursing, and then went on to get my DNP, got my anesthesia. So we all go through this different foundation, but we end up at the same place as far as the anesthesia portion. AAs can have a background in pretty much, they have to have a bachelor's degree in about anything, But, and they have to do prerequisite courses, a lot more science and like chemistry kinds of things. I actually think that medicine and the AA prerequisites are stronger in math and sciences than nursing. And that would be an area that I would like to see change for nursing. But I don't want to take away the human part, the social sciences and the psych stuff that we learn in nursing too, because I think that's important as well. But as far as for providing anesthesia, if you had more chemistry and more math, higher levels of both of those, it would give you a better foundation for the journey that you are partaking in here. But when it comes to the anesthesia part, we all pretty much practice the same basic skills, and we have the same basic knowledge base. Forward areas, any of you that want to join the military during or after your program, they always have all kinds of different ones. Air Force, I have to say that for Dr. Hogan and Dr. Benarzik. The Army, Dr. McDonough's retired, myself. Dr. McCarthy was in the Public Health Service, which is also one of the uniformed services. Dr. Self was an Army person. But they will help pay for school and reimburse you for school expenses. Now that is not the reason to join. Just like you don't want to become CRNA just for the salary. You do not want to join the military if it is not something that you will like and be good at. There's not enough money in the world to do it if it's not for everybody. But the benefits of it, not only getting sent to forward areas, but they have all kinds of benefit programs to help you pay for school and student loans, they pay student loans back and all that kind of stuff. So, and they also provide great experience, and then you could do something like that for 20 years and then still practice for 20 years in private practice and feel like you got a raise. I have not been to the forward areas because what I've done in my career is when active duty Army CRNAs go to combat, I go to I figured this out. I go to an Army hospital stateside mostly, and then take their spot. So when they leave, it leaves a void in that anesthesia department. So I go, where are there places that need people like that? So the first year I went to, it was 2008, I went to Tripler Army Medical Center in Hawaii. So that was really tough to do. And then the next 2010, I went to Augusta, Georgia, Fort Gordon. In 2012, I went to Landstuhl, Germany. And that's where I really got to take care of immediate people off the battlefield. And it was really, it was the first time in my career that I felt like, yeah, I'm in it. I had that combat mentality because everyone there had been blown up basically. And they were 24 to 48 hours out of that wound when I took care of them in Germany. That's what happens there on the battlefield. They get hurt, then they get sent to Germany and get stabilized, and then they get sent to an Army hospital somewhere closer to home. So that's when I first experienced, I think I had a little post-traumatic stress from that because every day, all day, I saw these young folks, 18, 22, that didn't have arms, legs, or appendages, genitals, and I'm thinking, how are they going to go forward in their life? It was emotionally, I knew I was doing a good thing to take care of them, but it was just really tough emotionally. I never told anybody really about it, but it was troublesome, and I noticed over time of taking care of people over and over. I was there for 5 months, that it did take a toll on me. But after I'd been there a few months, I was down at the local Irish pub in Germany. Yeah. Every place has them, just saying. So I was down there, and when I was down there with a bunch of CRNAs I worked with, there were some guys that came in that had been there to visit the new troops that had been wounded. And these are guys that had lost their arms and legs and stuff. And they had their prosthetics, and they were encouraging the people that had just gotten wounded. And so once I saw them, that they were living happy and vibrant lives. Now, I know they had lots of challenges, but once I saw that people can recover and get better, then I got better. I'm like, oh, I so needed to see these folks here. And then I would see them the next day up on the floors visiting people. It was totally cool. Liked it. All right, conceptual terms, okay. The triad of general anesthesia, this might be something you'll see somewhere else sometime. Analgesia, which is what? I don't know, is that a question? What does analgesia mean?
Lack of pain.
Maybe lack of sensation, controlling pain. If you're giving someone an analgesic drug, what are you thinking? Sure, yeah, controlling, removing pain. Hypnosis, you want them to be asleep under general anesthesia, and you don't want to move it. It's not a good day when the surgeon goes, incision, and this person, lifts up their leg or their arm or something, they try to grab the surgeon. That's not a good day. That is a bad day for you. Because you can pretend like you can hide behind those drapes. We call them the ether screen. We don't use ether anymore, but you can kind of feel like you're hiding behind there, but they all know the person's not deep enough under anesthesia whose fault it is, even if you're hiding behind that little curtain. They will find you. So regional anesthesia, tell me about regional anesthesia. Where would we be doing anesthesia as far as on the body? Like, okay, might do a shoulder, so peripheral, maybe, arms and legs, appendages. Where else?
Epidural.
Epidural, so I always think of epidurals, though we use them for other things, I tend to think of like labor and delivery, to help ease that transition. Spinal, so regional can be kind of central, talking about spine and spinal column and cord. So epidurals, spinals, or we can talk about peripheral blocks. You've heard of a beer block? Yeah, kind of cool. I haven't done one in years, but when I was at NAS, I got to do a bunch of them. I think we did them for like carpal tunnels, maybe. So you start an IV. You start an IV on the site where the surgery is. You're like, that just is counterproductive. Like, you don't ever do that. You never do that. If you have shoulder surgery on the right, you don't start an IV on the right, it goes on the opposite side. But for a beer block, you do that. So you start your IV, you have a tourniquet on, tighten up the tourniquet, you infuse, you inject, lidocaine, typically. It gets in there, everything gets numb. Still have the tourniquet out. You take the IV out, they do the procedure, and then you're going to release this tourniquet. But if you release it too soon, that lidocaine is really concentrated, and you can release it in the system and have, I don't know, seizures, death. You don't want to do that. So you have to have a certain amount of time, 20, 30 minutes. Depends on how much you gave and all that kind of stuff, and what actual local anesthetic you use. If it's a real fast case, I don't like them, because then you have, the case is done, but you can't let the tourniquet down until it's safe to release it, so it can get back in the person's system. So anyway, that's another example of like peripheral nerve block. Local anesthesia would be, if I'm going to take a little wart off right here, I'm going to localize that little spot, take it off, monitored anesthesia care, we already talked a little bit about that. It's different than like conscious sedation, because nurses that go through training, regular RNs can do conscious sedation, and it's usually like fentanyl Versed. But again, when we come in, it's usually adding propofol. Question?
Is the beer block, was that created by the same Dr. Beer that did the first spinal in the
I think
late
so.
90s? 1890s.
I was going to say, what? Yeah.
Like 98,
Yes. Yeah.
1890s.
And it's B-I-E-R.
Uh-huh.
Beer.
B-I.
Is it B-I-E-R?
B-E-R.
Oh, it's not? Ein Bier, bitte. Dankeschön. I learned a few some German terms when I was there. And also, I didn't do things in questions where I want to go toiletten, because after you've had the Ein Bier, bitte. So if you say Ein Bier, they bring you two, because this is one, this is two. I'm not going to do three, but if you tried to trick me out. Who does anesthesia today? Nurses, physicians, dentists, podiatrists, veterinarians, and anesthesiologist assistants. So veterinarians, Larry Ingberg, who's going to do a lecture, he got to do a case with I forgot if it's a chimpanzee, some vet that needed anesthesia, and somebody knew him and said, what about him? And it's a Balboa. Is that a type of chimpanzee? I don't know. I don't know about apes. I know him, came from apes probably once, but eventually. But yeah, he got to do anesthesia, so he took some pictures of it. It was totally cool. I'm like, was the airway the same? He goes, yeah, the airway was the same. You got a little ape under anesthesia. Wow. Larry got to intubate him and do all that, do the anesthesia. Well, he had this procedure done. Like, wow, is that cool? So it was either like an animal from a zoo. I don't know, it was from Jack's Zoo. I don't know the whole story, but when he's here, we should ask him about it. Because like, I just saw a picture and I'm like, are you kidding me? Wow. Really? Yeah, evolution's going the other way. But it was, what a cool experience. Most veterinarians do their own stuff for most anesthesia. All right, important organizations, AANA. If you haven't been to their website, I'm not sure if this one still works from your in the PowerPoint, but just Google AANA, and they'll have a student section. You also have an AANA number. right? So go in, look at what they have. Sometimes they'll have resources that will help you in your courses, but don't spend too much time because you might be interested in other stuff that doesn't relate to what you're doing now. So just look and see if you have some resources you can find there. It will tell you all the things you want to know. I'm not sure how many accredited programs this number changes almost monthly, so I'm not sure where we are. We have a lot of accredited programs, and we may even have more than 9 in Florida now. When I was in school, we only had we had one Gooding, which was in Panama City. We had FIU was only been open a few years. Barry, I don't know. Barry was going on when I was in school. My University of Miami started the program after the fact. USF has started the program after the fact. But when you ask about nursing anesthesia programs, you want to go with something that's university-based. You want to make sure it's accredited. And so in that respect, I'm biased, and you made a good choice here. Because this degree means something, and I'm sure you want to do postdoctorate work eventually in your life, but you can take this and go to another accredited place and get whatever PhD or whatever else you want to get, and it means something, where some places you wouldn't be able to do that. And because we're in a school of nursing and you have a nursing degree, you could add it to other nursing things. Whereas if you had a degree on MSN, for example, in anesthesia, but I lied, an MS in something other than nursing, and it was in anesthesia, you wouldn't be able to apply that to a DNP program. You'd have to get your RN to BSN. You have to get a BSN first before you do it. FANA, yes, that's the Florida Association of Nurse Anesthetists. And then the International Federation of Nurse Anesthetists, every 3 or 4 years, they do a conference around the world, different places. They've had them in Africa. A lot of times they're in Europe. I did a presentation, a poster presentation when I was in Scotland a couple of years ago, which was really cool because one of the guys there that was doing a poster is a guy I ended up working with in the Army this past time when I was there. And I'm like, you look really familiar. He goes, yeah, you do too. And I go, we were just talking. Eventually we figured out we met each other in Scotland, in Glasgow, and we were both presenting posters. Cool. Here's the Tax Equity and Fiscal Responsibility Act, and that's where, that's where it allows us to bill for our own services. But again, we have to have medical direction. And so you may ask the question, well, what is medical direction? Well, medical direction is the physician must do these things in order for them to charge, or we can charge our 50%, they can charge their 50%. This is through Medicare. In order for us to get paid, they have to meet these requirements. And some folks will argue that maybe these requirements aren't met all the time, every case, all day, and all facility. I can either confirm or deny that that's true or not, but that is what is supposed to happen for that 50-50 reimbursement to take place. Yeah. Oh, go ahead.
For that, the 50-50 piece of it, as we're becoming more autonomous, do we see that number going up in our direction, less than theirs?
It won't be under this billing type, under this billing format, but you could start your own practice and make it you pay the physician who's the medical director for you. You can say, okay, I'm going to give you 20% of what we make. Okay. Let's say your practice has 4 CRNAs or 6 CRNAs or 10 CRNAs. They get 20% of whatever your profits are. How are you the arrangement? You can make that arrangement however you want to. As far as Medicare and billing, it can only be like a 50-50, 50% to the physician, 50% to us. But they have to meet these conditions. There's not anybody watching that, by the way. Yeah.
How does it differ from cases that are like with patients with private insurance?
I don't honestly know, and that's a great question. It may be the same. They may still bill 50 and 50, but it's not a government, insurance reimbursement. But I don't know much about insurance. I really don't. I'm grateful I haven't had to use it much. But that's a great question. I don't really know any more detail on that, but it's probably similar in terms of how we charge. Question.
So did you say it could be like a DO, a dentist, or an MD that you're working on?
Yes.
If you work for a dentist,
Yes.
you get 50%?
Yes. Well, then that doesn't. If it's only this 50% thing is for Medicare.
Medicare reimbursement.
Yeah. Medicare reimbursement, and a lot of places set it up that way for other types of insurance too. But I don't really do much of the business part, man, my fun is taking care of every patient. I meet them, hi, my name's Dave, I'm a nurse anesthetist, I'm going to be part of the anesthesia team, I'm going to take care of you, Dave. And I build that rapport, that's my first anesthetic, you know, introducing myself, helping them feel comfortable, answering questions, letting them know what we're going to do, doing my assessment all within 5 minutes or less, because we're already going back to the room. So I don't know much about that side. There are other people on the faculty that do. Dr. McDonough knows a ton about it. Dr. Self knows a lot about it. But I don't know too much about that. That's like, I decided I didn't want to be an administrator in schools, I didn't want to be a principal. And I'm like, let somebody else go. But it is interesting, don't get me wrong. All right, there's my Curious George, yes. All right, this particular part of the PowerPoints are related to something Carol did. What's cool about this, you know, we have kind of been marginalized from a physician point of view as advanced practice nurses in anesthesia. And some of this history doesn't get taught and told, so that's why we're talking about it. But Alice Hunt was an assistant professor at Yale. Now I gotta tell you, Yale, since its existence, not only does it think it's fantastic, but it has a great reputation as a university, right? And so she taught anesthesia to physicians. You don't hear about, that's not in any of your books. So a nurse, anesthetist, was responsible for training lots and lots and lots of physicians, and you'll also find that true to be true with the Mayo folks. But what you hear about are the brothers, Mayo, God rest their soul, but you don't really hear from them much of the story. So that's why whenever we get a chance, we like to tell you a little bit about the fact that we are here, we need to be heard, we exist. A little bit about part of the story, and that's why I kind of like Naval Help too, because it proves our existence. Now I do understand that some of the political battles we're fighting, and I don't disagree with the fact that using physician-written textbooks give us a certain level of credibility within physicians' minds, as opposed to us using a nurse anesthesia textbook. So I get that mentality, and yet, as long as when we do our job, we are good, when you practice every day, that's where you build your reputation and the respect and the trust that you'll be seeking. Yep. She's awesome. This is her table of contents, and if you look in yours, except for a couple of the drugs that we don't use anymore, wow, it looks pretty much the same. What are you going to learn? You're going to learn this stuff. Yep. It has changed, thank goodness, through the years. But the content, this is what you're going to learn while you're here for the next couple of years. How is anesthesia different than other nurse practitioners? Well, we have family nurse practitioners, we have acute care nurse practitioners, we have pediatric nurse practitioners, we have whatever specialty type. Our specialty happens to be anesthesia, and our job is to help manage folks' pain. Make them, as far as for procedures and surgery, make them insensible to pain and keep them asleep and keep them from moving. Now, within anesthesia, there are areas that you can actually subspecialize in. In some areas, they will have specialty certifications you get, like in pain management. But a lot of them are like, you will train in OB. Everybody learns how to do OB, but I don't do OB every day. I miss it. I haven't done it. I only get to do it when I go to the Army. And I'm like, I don't tell them, man, I'm rusty. No, but I tell the people I'm working with, listen, would you mind coming in there with me? I might need some support, because I haven't done epidural in whatever, 3 years. I go, okay. Then I study ahead of time. I practice in my mind. So I'm prepared as I can be. And can I do it? I absolutely can do it. Am I rusty? Oh yeah. Just like, you know, if you haven't done an IV in a long time, you're like, man, you lost your zen. Like, where did it go? Like, you used to be the person that called on the unit. Go, hey, call so and so, because they always get it. And then you haven't done it in a while. You're like, kind of rusty. But it comes back to you. And I still know this. And even if my skills in certain areas get rusty from lack of use, I'm going to do it safely. And if I don't feel like I can do it safely, I'm going to get somebody else to do it. It is not below me to go, hey, like you asked me to go do a heart tomorrow. I have not done a heart in years. Now, can I do a heart? Yep. Did I do a bunch of hearts? Yep. But again, I know the steps and the processes. It's probably changed some since I did it. But I would need someone, I would say, listen, I haven't done a heart in 10 years. How do we do it here? What's the protocol? Can I get some support while I do it until I get back in the swing of it? I just tell them where I'm at, and they go, sure. If you're willing, and we want you to do this, and you're willing to do it, sure, I'll help you out. It's when you get thrown into a situation and you act like, or pretend like, you can do it, when you know the skills aren't there, or the safety's not there. Don't ever pretend like you are there when you're not. If you are, it's great to be humbly confident. But anytime I have deficits in terms of, I haven't been doing this for a while, I just tell the people I'm working with, and I say, yeah, I'd be glad to do that. Give me some support. Okay. And then they go, oh yeah, she's fine. You're fine. And anything you will learn and the things you will practice here come back to you very quickly. That I was grateful of. I wasn't sure at first. But so these are the different areas that CRNAs can kind of specialize, and they don't really require certifications or specialty certifications. It's just that you may end up being the heart guy, or you may end up in critical care. I have a CRNA friend that's also a acute care nurse practitioner, and she actually likes that more than she likes anesthesia. I'm like, why? I don't understand. But she wants to solve the problem. She wants to start from their birth and figure out how they got to where they are, and how she can fix it so they'll live forever. And I'm like, I just want to I want to build rapport. I want to get them through this anesthetic safely. I want to send them home. Then I want to go to the next one and do that. I want to do the next one and do that. So we're just made different. So I see her in the Army every few years, and I'm like, are you still doing night? She goes, yeah, I prefer that. And I'm like, okay. So she loves doing those post-op rounds. She can have all my patients all day long. She doesn't mind staying like 2 or 3 hours late. You're my friend forever. All right, types of anesthesia techniques. We know general, they're asleep. Regional can mean central as well as peripheral. Local in MAC. Oh, I love it when they say, oh, we're just doing a MAC case, acting like it's not as serious as a general case. It is. Now, the risks are generally lower, but if you're not vigilant, you're not watching every breath and every heartbeat, every vital sign that comes up on the monitor, that person can die. Usually when we're doing MAC cases, it can take a little longer, but you'll hear. What's that? That's the pulse ox, right? Yep. You better be watching. All right. Airway. I love it. You will be airway experts. And I don't know how much airway stuff you've had in the past. Probably when you did ACLS, everybody has to do an intubation, whatever. You're like, oh yes, it's cool. All right. It's different with real people. It's actually easier with real people than it is on mannequins most of the time. Because mannequins are that plastic, and some of them are pliable enough that you can do it. But with people, it's generally easier unless they have a difficult airway. And then there's nothing easy about that. And that's when I get someone that might be challenging. I have them ramped up. I have all my special little tools there, glide scope. I'm getting ready to intubate. And I call my anesthesiologist and say, hey, I'm getting ready to induce this patient. I'm going to wait till you're in the room because they may have a challenging airway before I push the propofol. They're like, okay, because they know what that means for me. It means I'm waiting. Everyone in the room is waiting until they get there, because if I need a second pair of hands, I want them to be anesthesia hands. So I push the propofol, I get ready to go, and I'm like, oh, not seeing too much, not even on the glide scope, not seeing too much, okay. So I know where it is, right? I know the esophagus is below and I know the airway is above. If I can see the, what would I be looking for when I go in there? I go in there, I see the tongue, I see the upper airway. What am I looking for that's in there? I am looking for vocal cords. Before you see that, you're going to see something else. You're probably going to see the epiglottis. Like, oh, I see the epiglottis, and you might see some couple little bones sticking out there. Like, those are the arachnoids. Like, you might see them, but you just can't see the vocal cords. You can't see it, but you know it's above that, right? If I get some kind of piece of the end, I know. So you have your tube, and you bent it so it goes up, so it's got like a hockey stick thing on it. And I go, and I'm like, this is still going to be kind of challenging. I go, I get it in, and it gets in. We pull the stylet, we put the cuff up, and we hook it up, and it's in the right place. And I'm like, and then I take my breath, my first breath in about 2 minutes, and I go, oh, thank you, Jesus. And I go, did I say that out loud? I meant it, because sometimes you think, I don't know if we're going to get it or not. And when you do, you're just like so grateful. Usually I just say it to myself in my mind, like, thank you, God, for helping me get that, because it didn't look easy. And occasionally stuff like that comes out, and I'm like, everyone around the room, sorry, but I meant it. It was true. So we'll talk about not only only the basic stuff here in airway, we'll also talk about advanced airway. And in this class, we just kind of introduce some of the bells and whistles. And when you get to clinical sites, and we're going to try to set up a simulation where you can see some of it and get some hands-on with that. But it's all cool. But you know, the best is DL. That's a basic skill that you have got to learn. It's probably a skill you don't have now. You have nursing skills, you've dealt with drips and hemodynamic drugs and all those kinds of things. So you know how to respond in a crisis, and you've got that. But intubating might be one of the things you're most nervous about initially, because you're going to be the expert right now. Like, I don't know what, but you think you know, and you do, but as far as kinesthetically, you haven't done enough of it for you to feel real confident. And remember that teeth are very expensive to repair. That's all I'm going to say about that right now. But yeah, you will get really good at it. There's no doubt. We're going to do our best to set up some simulation activities for you. I would say our program has needed to build a better simulation than we have. And we're working on trying to make that better. And I think your class will probably get to benefit some of that. Dr. McDonough does acknowledge that we are improving it. But his thing is too, your best simulation is really not simulation at all. It's when you go to the OR and you're taking care of patients. That's where you really, really learn and grow. Simulation helps get you prepared for that. And we're going to be working on trying to make that good experiences for you. We're going to do a whole lecture on assessments, and you're assessing everything. Because, like for me, I have 3 to 5 minutes to see that patient and make sure I can take care of them. Because in our hospital, they don't go to an anesthesia pre-op testing. Now they go to the surgical pre-op testing, where we've made an agreement with them and discussed if a patient has this comorbidity, we want these labs. We want a chest X-ray, we want an EKG, we want these labs drawn. So they've worked together, so we don't have to have a separate tests and specialty kinds of things. But the first time they see an anesthesia person is when I come up to the bedside. You're like, wow, it was right. Because it's like at UNH Health and a lot of the other training places. They go see it, not only they go get their labs drawn and all that kind of stuff, they see the surgical team, but they also see somebody from anesthesia. Not where I work, and we got 2 seconds or less to figure it out. Let me call the anesthesia. Can you get the light scope and get the pulmonary card outside the room? Okay, sure. I don't have much time to get it figured out, but you get really good at figuring it out pretty quickly. I like that part. All right. As you do your assessment, it's going to change based on patient comorbidities and the age of the patient. Are we talking about an adult? Are we talking about a pediatric? Are we talking about a geriatric? And I don't like how we define geriatrics, and we'll talk about that next semester because I'm getting closer and closer every year. I used to think old was, I don't know, 35. Actually, I used to think old was probably 25, back in the day, because there were only a few years that mattered to me. Like when I'm 15, I get my learner's permit so I can drive a car. When I'm 16, I get my license. When I'm 18, I can vote. Watch this. I changed the world, I'm sure. When I'm 21, I can drink. And I didn't drink when I was 21. I do now, but I didn't then. So that was not a big deal. And then after that, what is there? I mean, I really think about it. 65, Medicare, right? Medicaid. So I'm closer to that end, right? I'm 61, so I'm like really close to like, oh man. Where did it all go and how was it going? So yes, I'm going to teach you, I'm going to spend a lot of emphasis on this in this class because what you guys are providing, and I need your services, I want to make sure you got that. All right. Oh, management of fluids and blood. There's a whole science on this, and this has changed a lot even since in the 10 years I've been around because we have, again, ERAS protocol, and we have the goal-directed therapy. And it used to be like in level 1 traumas. A lot of things we learned from the military, as bad as war in combat is, we get a lot of casualties real quickly, and we can learn how to save people better, which transfers over into the civilian world so we can respond to traumas better. And that's kind of I have mixed feelings about that. But we do learn a lot of good things from bad happenings. So this is an area that has really changed. We used to think lots and lots and lots and lots and lots and lots of fluid. We don't think that way anymore. We think give them what they need based on the monitors that we have and how they're hemodynamically responding. We're done shortly. I will be done shortly, sir.
That's fine.
Okay. All right. So anyway, this is an area that's different and changing And Dr. Pavlotti will teach you about some of the monitors we use for goal-directed therapy. Dr. McDonough comes in and talks about ERAS with you, so you'll learn a little bit about that. My friend Larry Ingber comes in and talks about fluid sum and blood sum. I had a thought, but I'm not going to share that. Okay. Dr. Self or his representative will be talking about positioning, and this becomes important, especially because under general anesthesia, that person can't move, they can't wiggle, they can't, if something's on them and it's causing the blood flow to stop at their hand, like when you're asleep and you're laying on something, you wake up and you move, so you stop that, right? You stop and you move and the blood flow continues. But when they're under anesthesia, it's your job to maintain that for patients. You've got to make sure everything, their hand or toes are not turning blue. You've got to watch for that. You've got to watch to make sure they don't have nerve damage. And it's all based on positioning and padding and making sure you're taking care of them. Because again, they're asleep. They're like a little rag doll. And you've got to protect them and take care of them because they can't do it for themselves. And isn't that what nurses do? Isn't that what we do? We do things for people that they can't do for themselves, right? And under anesthesia, even more so, because you're the one that induced that place that they are. All right. Ms. Carroll will spend time talking about care plans related to the scenarios. And again, as part of the practical course, you'll have 3 care plans that are due. If you haven't looked at that syllabus, take a moment to look at that. It is later in the semester. You will have 4 to 6 days of observation in one of the hospitals. And it really is considered observation, but some sites will let you do more hands-on than others if you get the opportunity. Be willing to do things, but really use the time to watch, and see yourself in this role. And you'll first go, how do they keep track of all that stuff? They have to keep track of a million things in 30 seconds or less. Like, how do you do that? You'll get good at it, but it will take time. So we'll do some observation days. You'll learn how to put things into Typhon, which is how we track all the different cases and types of cases you do. And that we need for accreditation in the school to say, you can graduate because you've met all these requirements. The care plans you do the first few semesters while you're in going to clinicals, and that's just to know that you have at least thought out one case of the day to give you a plan. And a lot of people, the people that get the most out of those care plans are the people that do their own. Some people, there's so many probably repositories and places of your mentors and peers that have, you can just go, oh, it needs to be on this topic. Shh, don't do that because you won't learn the process. You need to learn how to think, and that's what these care plans do. You will get to the point where the care plans, you know them so well, and you're like, this is why are we doing this? I don't need to do this anymore. But you have to get to that place that you already know the stuff before we drop the care plans, okay? So right now it's like, it will help you and be a super good guide. The Jaffe, is it Jaffe and Samuels still book? I didn't know if Samuels was still on there or not. I looked at that because I didn't know anything about surgery. I've never been an OR nurse, and I was like, I don't even know, I think I know what that is. I don't even know what that is, but that's a good guide. But how the anesthesia plan they have in there is just one of many options. But at least it gives you something to start with. When you call report to your CRNA the night before and say, here's what the plan is, and they'll say, oh, no. The way we do it here is, and you go, okay, plan B. Because almost everything can be done plan A, B, or C. All right. I think we're getting close. Exams, we've talked about. The first one, 25% of your grade, 25% of your grade on the second, and 40% on the last one. And then what's the last 10%? Yes, it is. Look at that. I miss Nagel House and Clout. All right. And my favorite. Questions. My job as your instructor here is to assist your learning. And you will find that this is graduate level, doctoral, and we will treat you that way as grown adults. If I say read the syllabus and the policies and things that I've put in the class, I'm expecting you to do that, and I will hold you to it. And if something comes up in the course of your career and you haven't followed one of those guidelines, I will refer you back to that and you go, but I never read it. And I go, okay, well, there's the first problem, because you're responsible for it. Now, I could go over it and read it to you. I have chosen not to do that, but I do expect you to know those things and what your responsibilities are, what the school policies are. But know this, my job is to facilitate your learning. But you will probably feel like that you are teaching yourself in all of your classes. That's the kind of effort it takes. They're not even really helping me, they're just giving me all this stuff. Yep. Yep, pretty much. We're gonna guide you and lead you and facilitate your learning, but it's on you. It's on you. You are your best teacher, best mentor. We are here to guide you through that journey, and we will do our best to do that. That's why I'm here. I want you guys to be able to take care of me and the people I love. And, any questions? Take a quick break. Dr. Schwartz is up next.